Good evening. Now we're going to look at some nursing assessment skills. We're going to start off talking about pulses. Be sure to review all your pulse sites. Be able to identify if presented an image of a body, where each site is with its proper name. Keep in mind one particular one that can mislead people is if they ask for a pedal pulse. Remember that could be in reference to two different sites, the dorsal pedis and the posterior tibial. If you're asked for assessing a pulse deficit, remember that we'll take two nurses simultaneously verifying the apical and radial and assessing for a difference between them. This would indicate ineffective cardiac contraction. And also remember when a patient has any kind of procedure that would affect the vessels, anything that might cause decreased blood flow, we want to make sure we're always checking for a distal pulse. Eyes. Perla, people often confuse the accommodation at the end of the perla there. So remember, if they are asked about accommodation, that would be when you bring a pen light or something for the patient to focus on, closer towards the patient and farther away, and you should have a pupillary reaction of constriction dilation with the near and far. Please remember that if the eyes are not doing the same thing, there's no such thing as one-eyed perla. Often in simulation labs, I'll have students tell me one eye is perla and one eye is not. That is not physically possible. Glaucoma drops. We talked about this with Cahoots already, but a reminder, when we have prescriptions, it is in order to decrease pressure, not a pain medication, not restoring sight. Now that might be benefits, particularly pain relief, but that is an effect of the decreasing pressure. Vital signs and safety considerations. We'll always be keeping an eye out for any kind of signs of bleeding, taking bleeding precautions. If somebody is at risk for bleeding, we're going to obviously be very careful. Sometimes a question and answer could be as simple as being cautious not to bang or injure the patient. Remember to watch out for contraindications. Maybe they have a mastectomy, or maybe you have a fistula. You might have to use another site. It's possible they might not be able to have access to arms for blood pressure. You might need to actually use a blood pressure on the leg. If they do have to put a cuff on the thigh, make sure that the bladder of the cuff is over the artery at the posterior of the leg. When it comes to accuracy, watch out for things such as temperature. If the patient has been consuming anything hot or cold, maybe an ice cold water, and their temperature now shows at 95 degrees. Always watch out for things like fingernail polish if you don't have a good pulse oximetry reading, or check even see if the hands are really cold. They might need to be warmed up. The circulation might not be sufficient to get a good reading. With your finger sticks, remember, by the book, proper procedure. First drop of blood comes off will get wiped off, and then you'll use the next drop to get your actual test. Skin. We always want to be looking for color, moisture, tartar. Keep in mind the different sites where turgor could be assessed. You might be used to just 1 or 2 spots, but per the book, it could be tested over the abdomen, forearm, sternum, forehead, or on the thigh. Yes, you might not have ever seen it tested in some of those spots, but remember, book answer, we got to make sure that we check anywhere that they say possible. Braden scale. Good thing to review. Remember, higher score is better. Perfect score would be a 23. So if you have a patient who his score is decreasing, then you'll want to start doing interventions. If they get into the risk categories, even at a mild risk where you see is 15 to 18, then you need to start intervening, maybe do a turning schedule, some positioning. Want to make sure that we prevent any kind of skin breakdown. Auscultation, lung, bowel, and heart sounds. Now on the page here, we've put a couple links to videos. Be good to review the different lung and heart sounds on there. They may ask you to listen to a sound bit and identify what kind of abnormal sound is in that video. With your bowel sounds, we have to remember that listening to each quadrant could be up to 5 minutes. So if they present you with a scenario, you've been listening to bowel sounds for 3 minutes and you haven't heard anything, you're going to continue to listen. It might seem like a very long time, but it's very important to have it accurate, and we're always going to stick to procedure by the book. Secretions, we have our different types of secretions. After this, we're going to have images of these different types of secretions. You want to make sure you know proper terminology for these. Also remember, we have terms such as hemoptysis. Make sure you can identify that. We have blood in the sputum, or hematemesis, blood in the vomit. So review associated terms with these types of secretions. Now we have our JP drain. Blood, pretty clear. Remember, blood, sanguineous. In this image, it might be a little hard to tell, but there's a bit of a mix of the blood and yellow serous fluid. So then we have serosanguineous drainage. Serous, now it's a thinner yellow. It's not the thick, chunky stuff that we're going to see in the next slide. Remember, a little bit of yellow fluid. It's nice and clear and clean looking. That is a normal thing. It does not necessarily indicate infection. Serous fluid will come out of a wound with normal drainage. But if you look like the next slide here, now that is not good. Indicative of infection. If it's purulent drainage, remember that's old dead white blood cells. That tells you right there we have an infection problem. Stages of pressure ulcers. This is also in your book. Make sure you can identify by description what stage the wound would be. If we don't have really identifying features, maybe there's just a big dark purple spot, we can't tell how deep it is, it's unstageable, or suspected deep tissue injury. Now by description, which one did you get? Hopefully stage 3. A lot of times people see the word fascia and they want to go all the way to 4, but go back and read your descriptions. Make sure you can distinguish between the two. Cultural considerations. Important to always maintain as much as possible modesty, of course, with the physical body. Sometimes this could also be with questioning. Sometimes different culture backgrounds, you say if you're asking a question about sexuality, they might be very embarrassed. You might want to reword the question. They may present the patient as somebody who English is not the primary language, but that does not mean they don't understand you. Don't get drawn into that just because somebody doesn't want to answer a particular question. Remember, if you are already assessing this person and speaking English with the individual, don't start assuming that suddenly they don't understand. Other related considerations could be religious type, maybe they won't take blood products, or there could be dietary considerations too. So when they present with the culture, you want to review, just keep in mind those common ones. They're definitely testable items. On to restraints. Remember, we have physical restraints and chemical restraints to consider. When we have somebody in the physical restraints, such as wrist restraints, remember that will have to be loosened periodically. Range of motion will be done. Should be able to get 2 fingers underneath the cuff, but we don't, of course, want it to be too loose and slide off. Where and how you tie it, important. Make sure you have the quick release knot, slip knot, and make sure it's tied in a proper place on the bed where there's no moving items and the patient will not be able to reach it and untie it themselves. Physical restraints are defined as any manual, method, or physical or mechanical device, material, or equipment attached or adjacent to the resident's body that the individual cannot remove easily, which restrains freedom of movement or normal access to one's body. So to put it simply, if the person is not able to undo the device themselves, it is considered a restraint. Even say like a seat belt in a wheelchair. You might think, well, we should better buckle this up because we don't want this person to fall. But if the individual is not able to undo it themselves, it will be considered a restraint. Be careful with any kind of use of chemical restraints too. It is viewed in the same way as if you were securing somebody, to a bed or something. You always have to use it as a last resort method. Oxygen administration. We want to review the different types of devices possible. Make sure you remember too what kind of flow rate was appropriate for the different devices. We don't want to put 15 liters trying to run through a nasal cannula, right? That's not a possible thing. Considerations with the different devices too, such as when you have a cannula, you have to keep an eye on the top and back of the ear, at the cheek and nose, of course. If it's a higher flow with the cannula, of course, we want humidified air. If you have a mask device, you can go up to, let's say, 10 liters. If you have a non-rebreather, remember that bag needs to be inflated before you can ever put it on and at a high flow oxygen. If you need a device that has the high level of precision for oxygen flow, remember that's the Venturi device. They have inserts that you can choose the specific percentage of oxygen being delivered. Also a reminder, your COPD patients, we don't want to go more than about 2 to 3 liters. Those are the ones that are at risk for hypoxic drive. Too much oxygen means their body may stop breathing. Your dialysis patient will have expected changes from before to after. As the process concludes, they will have a lower blood pressure, and you'll actually be able to measure a weight loss. Now, it's pretty tough on the body for this procedure. A lot of times people wind up having nausea related to it, so if it's happening around a mealtime, you may have to hold the meal for them so as they feel good enough, they'll be able to have it afterwards. Patients with sleep disturbance. We want to do the simplest thing for them that we can first before we start jumping on the Ambien or any other kind of other medication. Let's check out the rooms. Is the room got a good environment? Is there a light or a noise going on that we can prevent? Maybe they actually just need maybe some comfy socks or a blanket. You might want to check what their history of sleep patterns are. Some of us are up really late at night and don't want to be up early in the morning. If your patient wants to sleep in and there's no reason stated that we would have to be up, let the person sleep. Check the room out. Make sure that it's environment provided for them. Or it might even be as simple as they may want a back rub before going to bed. Of course, we want to watch out for eating late at night or anything that would be a stimulant. But just always keep in mind the simplest intervention first. Infection and interventions. Of course, we have our usuals to watch out for: elevated temperature, heat and redness at a wound site, a red line coming away from a site, that's a dead giveaway. And of course, our labs. You have the really elevated white blood cells. That's generally a pretty clear sign of infection. What do we do with interventions? First off, very pertinent to the times right now, wash those hands. Still a very key factor. And remember, in a room, especially if you're keeping an eye on those UAs and those tests, that washing of the hands needs to happen in the room with the patient. So they can't be coming out to the nurse's station to go wash there because they're more comfortable with it. Any kind of PPE, if you're taken off, thrown away at the room, and the washing needs to happen at that spot, not coming out and potentially spreading the infection elsewhere. Keep in mind when they present different diagnoses, what kind of PPE would it need? Do we just have standard precautions? Are they going to need an additional mask? Something for droplets? Be very careful with the wording of each question. If anytime somebody has visibly soiled hands, the hand sanitizer is just not going to do it, folks. Now, it's good when you're exercising caution, but hand washing is still your number one choice. Also remember, for prevention of infection for somebody who's in bed a lot, good old turn, cough, deep breathe. Make sure we are preventing pneumonia. Okay, if you want more time, just pause this. But did we come up with number 4? Right off the bat, you see 2 big risks: the abdominal incision and an indwelling catheter. Also keep in mind some of the answers, like number one, we start off with the fever. If they already have signs of infection, it's not a risk for infection. To be at risk, you don't have the infection yet. So if they already have the indications of infection, then it's too late. They're no longer appropriate. The risk of infection is no longer an appropriate diagnosis. All right, there are many things that could be associated with confusion. We have our electrolytes. Common one there could be low sodium. It's often related with confusion. Anemia. You don't have enough red blood cells to carry around the oxygen. The lack of oxygen itself can lead to confusion. Decreased renal function. If you don't have enough nephrons doing their job, toxicity is going to be a big potential problem. If you're not excreting these things, it can build up and that could lead to confusion. With endocrine disorders, it could be too much or too little. Hormones can wreak havoc in one's body. Too much or too little insulin, a low thyroid, all these things can lead to confusion. Pain, if you're not getting proper pain relief, or you may be presenting with an altered breathing pattern because of the pain. Anesthesia, I've had that myself, probably some of you have. While that's still in the body, well, it might take a little time to come to. You might not make sense of things for a while. Don't expect your patient to. Make sure you're treating them the safest way possible. Safety is always very key. So remember, safest thing for the patient in any of these conditions. All right, this one often gets the wrong answer. People immediately see epidural and get drawn to the headache. There are considerations there, yes, but what we're looking for right now with the pain medication specifically is the hypoventilation still. Trochanter roll. We just want to make sure you are familiar with these. Now, a lot of places these days, they will just put a towel, line it up along the side of the patient. But what we want to know is this is going to present external rotation of the hip. We're just trying to maintain alignment. Factors affecting wound healing. Remember, with age, particularly it's the elderly that we're looking at that will have a harder time with wound healing. If you have a diagnosis of PVD, then you have impaired blood flow. Of course, good blood flow to a wound, very important, bringing all the necessary nutrients, everything the wound needs for healing. Decreased immune function, antibodies and monocytes necessary for wound healing, and also the platelets and other blood cells will be decreased and can affect the oxygen delivery. Reduced liver function. There we have impairment of synthesis of the blood and clotting factors. Reduced lung function. Then we're having reduced oxygen that's needed to synthesize the collagen and new epithelium. Nutrition. We want to make sure they have a good diet and that they're eating well as much as possible. If the patient is eating well, you will definitely see quite a difference in how well they will heal from their wounds. The vitamins and minerals, remember the vitamins associated, people always think about like vitamin C and have your proteins. keep these things in mind. You never know what they could be asking about it. Lifestyle. Regular exercise, of course, that's a good deal. Smoking, big consideration. Remember, that is a vasoconstrictor. So, again, the wound will not be getting all the supplies and nutrients that it needs to heal properly. Medications. There are several that could actually interfere with the healing process, such as steroids, NSAIDs, heparin, or anti-neoplastic agents. Chronic illness, if they have disease process before the wound, that could also slow down the healing process quite a bit, such as diabetes, of course, cardiovascular diseases, or maybe immune system disorders. All those could have a negative effect on the healing process. And of course, infection, that's going to slow things down quite a bit. We need to get the infection cleaned out, get some nice, good tissue so it can heal properly. And a review of some terms. Abduction versus adduction. I think a lot of us have learned adduction, the word add is in there, we're adding to the body, so we're bringing limbs towards the body, and abduction is going to be putting away. Remember, for something like a hip replacement, you'll have that wedge or abduction pillow that would go between the legs and keep them apart from each other. Dehiscence versus evisceration. D before E. Remember the dehiscence, that would be the opening up of a wound. Evisceration would be the protrusion of the intestinal. So if you remember D before E, one has to happen before the other. Now you could have a dehiscence without necessarily an evisceration. If you do have a patient that presents with intestinal materials coming out of the wound, remember, one, of course, we're not going to have that person move. We're going to set them down. They're going to need surgery, so make sure they're not going to receive anything by mouth, and we need to prevent any further injury. Any intestinal materials presenting, that will need to be covered, and it needs to be kept moist. No dry dressings on there. Remember, if we dry out intestines, they're going to cause damage. Glycogen versus glucagon. Remember, glycogen is the stored form of glucose in the liver and muscles, whereas glucagon is the pancreatic hormone that the body will produce in response to low glucose levels in the blood. Afferent versus efferent. So afferent is heading towards the central nervous system, so I like to say it's coming at it. Efferent away, so it's exiting the central nervous system. So if we can look at that E and think exit, then I'll remember it's going away. Dysphagia versus dysphagia. Always a tricky one. So when you have the G, I think of the G for gag. They have the swallowing problems. When it's the SIA at the end, that is your speech. Finally, beta versus alpha. Just remember that the beta, those are the cells that produce your insulin, and the alpha cells produce the glucagon. Considerations for the surgical patient. For your pre-op patient, what would the PN responsibility be in regards to consent? So the PN, it would be verifying that the informed consent is there, completed, and signed. If it is found that they do not have a signed, completed form there present, the charge nurse or surgeon, whomever they're presenting, needs to be informed right away. This needs to be taken care of before the patient can go into surgery. and consent would have to be given before medications are instilled to make them unable to sign. Now, the PN can be a witness, but it's not their job to actually obtain it and explain the procedure to them. Intervention and PO status, of course, we're going to ask the patient if they have eaten or drinking anything. It's usually after midnight that we're preparing for surgery. Now, if they do say something like, well, I didn't eat, but I had some water, as opposed to just immediately saying we have to call it all off, we're just going to gather the information and present it. So, what time did you have? How much did you have? And then it will be up to the surgeon whether they should continue or not. Sequential compression devices, remember that those go on in order to prevent a thrombus from developing. If there were a thrombus to be there beforehand, we would not want to put that on the patient's legs, because if there's already a clot, we don't want to break it free. Remember that applying sequential compression devices is actually a skill in your fundamentals book. So that'd be a good thing to look at, and mostly want to take a look at how they fit on the body, on the legs. So as you see in the picture there, they are designed nicely where it fits like the bend of the knee and such, very appropriately. We just review that, make sure you're able to look at it and know how to apply it to the patient. Post-op, some reportable findings. Of course, one of the first things we usually think about is bleeding. So we're going to watch out for signs and symptoms. You might be able to see dressing getting saturated. Remember, if you see a dressing with some blood on it, that's going to be expected. Think way back in fundamentals where when there's a little bit there, you outline and put the time, and then you can come back and reassess, see how much more it's spread, do another outline, put the time, and that will give us an idea how much bleeding is going on. If a dressing gets saturated, remember, we're not going to remove a surgical dressing, we'll reinforce it. And one of the most important things that we can do for assessing the patient when we see bleeding is checking the vitals. Look to see, is the blood pressure dropping? Is the respiratory rate and heart rate increasing? Sometimes if it's post-op, medications are going to mask some of these findings. But don't forget the basics. Do your vital signs. Look for the indications. Complaints of pain. Now in post-op, it is expected that there will be some pain. But what we want to make sure is the pain is being managed properly. So is it sufficient? Are they reporting a constant 9 out of 10, or does it go down to a 2 or 3 when medication is administered? Remember also side effects. We're going to have decreasing respirations in particular, and in a little bit of time we'll start having to make sure we have good bowel care. Along with the pain medication, remember, of course, we want to administer it, try to control their pain as much as possible. But if the patient is asking for pain medicine, especially a post-op patient, remember, this is one of the things that we're looking at for confusion. So we're going to want to look at when the last time they received pain medication before giving more. All right, that concludes for tonight, and we will talk again tomorrow. Goodbye.